No question? Okay, let's go to Bali, to Udayana. Do you have any question? Participants from Udayana?
We don't have any question right now.
Okay. Now, I would like to invite Dr. Effie to first answer the question about the opinion on induced abortion for women with HIV. Yes, you can. Yes, you please. Induced abortion.
Okay, thank you. I would just like to point out that in Buddhism, it's breaking the first precepts, which is to refrain from harming a living being. But again, this case is from the woman, so she knows what her precepts is, and if she wants to keep her precepts, then she's not going to do the abortion. But again, the Buddhist ethics call for everyone to be responsible of her or his own behavior, so we leave it up to her. She knows that if she does the abortion, she will break the first precept.
Very clear answer. Now, Dr. Toha Muhaimin, your answer?
Yeah, to me, to have induced abortion for the woman positive is, I think it doesn't, I don't agree with that. It's not even for the HIV positive woman, but even for the unpregnant, not negative HIV woman. So I don't think it is good way, because but in Islam I think abortion is debatable. A lot of what is it? A lot of opinion from the religious leader, because when we say abortion, when do we start the life? That is the point. Starting when the life start, it is debatable when. So some people say that before 40 days is okay, and before 120 days. So it depends on the opinion of them. But in my opinion, abortion is not the way to do that. In HIV positive women, the proportion of or the probability to have positive baby from the pregnant woman is very low actually. Mostly after the taking ARV, sexual cesarean, and then not giving breast milk. So even without any means, any intervention, the probability is 25 to 40. So it is very small. That's my question, my answer. Thank you.
Okay, thank you, Dr. Toha. The last response, I will invite Sister Torres to answer this question about induced abortion for women with HIV positive.
Yes. Can you hear me?
Yes. Yes, we can hear you.
Okay. The Church desires to affirm without qualification the value of every human life, and she is called to defend it. So every Christian's ultimate responsibility is to protect life, and more specifically, to protect against HIV transmission, especially among those who have the least capacity to defend themselves. And these are the child in the womb of the mother. So with this particular statement, I would still uphold that human life is to be defended. And if ever an HIV positive pregnant woman is to deliver or is to keep her baby up to the time of delivery, she has other means to do, like she can take the ARV treatment while having the pregnancy on, and just as what the doctor said a while ago, she can deliver by cesarean. And here in our country, in the very congregation where we have the institutional care for children of those HIV positive parents, so that when they are still in the process of keeping their pregnancy, they are helped by this institution up to the time they get into the actual delivery, and even up to the time that they care for the baby that has been delivered. Thank you.
Thank you, Sister Torres. Dear participants, especially participants from Salemba and Depok, I should say sorry because I cannot invite your questions. But you in both sides have the opportunity to have the online discussion after this offline discussion after this online broadcasting. I'm so sorry not to invite some questions from Salemba and Depok. Okay, all participants, today we have learned very valuable things and message from three religions, from Islam, Catholic, and Buddha. All religions already, resource persons already delivered the main message, the principles of those religions, how to prevent HIV and AIDS. If you still have more questions about this religious perspective, you can upload your questions to our homepage, and then later on we will deliver the questions to all the resource persons. Sister Torres from Philippines, Dr. Toha and Dr. Effie from Indonesia. At the end, I would like to thank Sister Torres. Thank you very much for your time, for your valuable informations. Also for Dr. Effie, Mr. Untung, and Dr. Toha for your time and your contribution to these sessions. So if there is more questions from the participants, we will deliver to you and ask your assistant to answer the questions. Okay, I will close this session. Thank you very much for your attention. Please give an applause to all the resource persons for these sessions. We will have a short break to prepare the next session. We will have Pak Ishar at Salemba, and hopefully Ibu Naf is already there also. We will have a short break. Banyak sekali pelajaran dari situ. Bapak, thank you. Jelas sekali jawabannya. Use abortion, no.
Mat, Dian. Itu narasumbernya sudah di situ.
Udah, Pak.
Oh, udah. Mat, nanti diganti-gantian aja, Mat, slide-nya, terus ke pembicaranya, slide pembicara gitu aja. Bukan studio, meja di depan. Enggak, emang ada meja di depan. Iya, iya, berhadapan dengan mahasiswa. Mat, nutupin. Nah, di situ aja. Nah, ya.
Halo, tes. Tes, suara kedengaran?
Ya, kedengaran Bu. Terima kasih Bu.
Okay, we're ready for the second session today.
Okay, stand by.
Tapi kenapa gaung ya?
Ya, ada feedback, Mat? Okay, I will check with all the side first. Erlangga, are you still with us? University of Erlangga? University of Diponegoro?
We are with you, sir.
Okay. University of Diponegoro, are you still with us? Hello?
Yes. Yes, can you hear us?
Yeah, we can hear loud and clear. University of Udayana, are you here with us? Hello, University of Udayana? Hello? Okay, we move to University of Gadjah Mada, Yogyakarta. Are you still with us? Gadjah Mada, are you still with us? Okay, Monash University in Malaysia? Hello, Monash? Okay. The Philippines? Briginet, are you still with us? Hello, Philippines?
Yeah, but we don't have any participants. Sister Torres has already left.
So are you going to close the sites, or are you going to participate in the sessions?
I think we will close the site.
Okay, thank you.
Thank you.
Okay, you Depok, still with us? Hello, UI Depok? University of Indonesia Depok, are you still with us? Okay, we will start anyway. Okay, before we start, I will do a short introductions for our speakers today. Dr. Nafsyah Mboy. Dr. Nafsyah is the Indonesian National AIDS Commission Executive Director, providing leadership and management of HIV/AIDS response for the country. Dr. Nafsyah is a medical doctor and trained as pediatrician. She also holds a master's degree in public health from University of Antwerp in Belgium. Dr. Nafsyah holds several key positions, including WHO Director of Gender and Women Health and at WHO Geneva, and she is also chair of the UN Committee on Child Rights. Ibu Naf, the floor is yours.
Thank you, Pak Ishar. Actually, let me start by saying how happy I am and appreciate University of Indonesia by organizing this. Secondly, let me also make some corrections. I'm not the executive director, I'm the secretary. But yes, indeed, I'm the boss, if you understand what I mean. Friends, good morning. This is a good opportunity that at the end of your course, you would like to hear or you would like to participate in this session talking about policy and HIV prevention. I know that you have already have a lot of exposure to the epidemics in Asia as well as globally, and you also know that there are different levels of the epidemic, and we have a low-level epidemic in Asia especially. We have low-level epidemic, we have concentrated epidemic, we have some provinces especially in Indonesia, there are 2 provinces with low-level generalized epidemic. But we don't yet have hyper-endemic scenarios in Asia, thank God. And as you know, each level we should endeavor to have policies related to the type of our epidemic, whichever level the country is. At the moment, I will assume, or I will talk mostly on policy for concentrated epidemic levels, which means that there is a high concentration of HIV or high prevalence of HIV, more than 5% in some subpopulations. We also know that policy is very closely related to programs, actually, because policy will provide the guidance, will provide the strategy, will provide the structures, but also it will provide the enabling environment so that programs can be carried out. On the other hand, programs, before to be implemented effectively, need policies to be able, again, to enable the program managers and the program or the program to be carried out effectively. Okay, let me start. I would like to be unconventional today. I would like to start with conclusion, and then thereafter a little bit about the HIV/AIDS in Asia and the trend of the epidemic, which actually you have already heard. Principles of HIV prevention, I think you also have heard. Then the 2 most important, the key of this lecture today, first is essential policy issues in HIV/AIDS prevention, but also essential programmatic actions, and then some further reading. My friends, maybe you are a policymaker, or maybe at the moment you are going to be a policymaker. So my statement for today is, first, that HIV prevention must be the mainstay of the AIDS response and should be integrated with treatment and care. HIV programs should aim to prevent the maximum number of new HIV infections. Okay? And this can best be achieved by focusing on populations that are most at risk. Those are the injecting drug users, sex workers and their clients, men who have sex as men, and here is including the transgenders. In Indonesia they're called waria, and sexual partners of all these groups. This is easier said than done, because as you know, these people who are our sisters and brothers, who are, they usually are marginalized, stigmatized, judged by their behavior, but also, in some cases, they are criminalized, like injecting drug use in some countries is a criminal act. Sex work in some countries, it's criminal as well. Prevention programs should be prioritized on the basis of their impact on lowering new infections. But proven interventions should be scaled up. Epidemiologically, the critical should be scaled up to reach the critical 80% coverage thresholds needed to achieve a significant impact. So in most Asian countries, we have not yet reached 80% of most at-risk populations or universal access. And a minimum of about $0.30 per capita must be spent annually on prevention, because every $1 invested in prevention in early epidemics can save up to $8 in averted treatment costs. As you know, treatment is very, very expensive for any disease, but especially for AIDS. Let me show you this. The AIDS Commission in Asia has shown us how to prioritize our resources, our limited resources, by taking as our indicator averting new infections, prevention. So that is the impact. And then compare it to the cost of intervention. The first one is low cost, high impact. That is prevention among most at-risk populations. High cost but high impact is antiretroviral treatment and prevention of mother-to-child transmission. So the question today actually, an HIV positive woman does not have to abort her baby. She can just have access to treatment with antiretroviral, and also it's not necessary for sexual cesarean, and also it's not necessary to give, or it's good to give breast milk, okay? So that's high cost, but it has high impact on the epidemic. Low cost, low epidemic is general awareness programs through mass media and other channels. We know that most countries are doing this one. And then we have high cost, low impact is universal precautions and injection safety. So this also is very high cost, but very low impact, okay? And that is why we have to focus on these two, which is low cost, high impact, as well as high cost, high impact, because it will avert the highest number of new infections. HIV in Asia, you already know that almost 5 million people living with HIV in 2008. Some 500,000 people are infected, and 300,000 died of AIDS in 2007. And HIV transmission is driven primarily by injecting drug use, unprotected commercial sex, unprotected sex between men, and sex between infected husbands and their wives. Okay? So one is through injecting drug use, and the rest is sexual transmission. Now let's look. The Commission on the Asia Commission on AIDS did a study and reported that in Asia, the drivers, the risk that fuels the HIV epidemic in Asia are these. 75 million men in Asia visit sex workers, which is 2 to 20% of adult men. 10 million men who inject drugs, and 10 million men who have sex with men. So there are 95 million men who are at risk. Among the women, we have 10 million women who sell sex. Not lessen the spread of the epidemic, and that is why we have to have
Welcome to Unified Conferencing.
So, and prevention does not yet have an urgent enough priority in Asia, even though effective prevention is both feasible and affordable. We know what to do, and we know how to do it. Some principles of HIV prevention are these 6, which is respect for human rights and gender equality. Again, this is very easily said, but in practice, to put on paper as policy may not be accepted. Because you can say, okay, an injecting drug user is a criminal, but still, they have their human rights. They still, even though they are put in prison, for instance, they still have the right to life, to live. They have the right to be healthy, the right to education and all that. So this is very important. And to talk about gender equality is a lot of lip service. Even in all our papers, you can see gender equality being the policy. But in practice, if in social life, a man can say, look at a woman as just something that he can rent for a few hours for his pleasure, and that is acceptable in society, then where is the gender equality? So there is still a lot to be done in this aspect. We can write the policy. We should. But implementation or enforcing is another matter. Adaptation to epidemiological, social, economic, and cultural context. Indeed, this is a very important fact. You have to know your epidemic before you can have the right policy. Like here in Indonesia, we started with mapping and estimation of the numbers of most at-risk populations. So according to the maps, we were able to target our interventions, especially we were able to target our interventions in a comprehensive way, which is prevention as well as treatment and care for those who are already infected. Evidence-based policy and programs, this is very true, and it has to be. All policies should be based on evidence. If you don't have the evidence, look for it. Comprehensive in scope, as I said, starting from prevention, care support and treatment, even terminal care. There has to be sufficient coverage, 80% of most at-risk population, scale and intensity to make a critical difference. If you don't read the coverage, so you have to set high targets, ambitious targets, and then look for the resources. And definitely participation by affected communities, those that are not yet infected but are at risk of infection, as well as those that are already infected. So we know the course of HIV and AIDS. We start prevention actually here. For those most at risk. Of course, there are activities targeted to the young people who are at the moment not at risk. That's fine. But as you know, this is low impact, low cost. Okay? So, but if you have the resources, yes, that's very important. Especially young people should get information not only about sex, but also about illicit drugs or narcotics. But we cannot just this is the most important prevention that we have to do for those most at risk. But even for those who are already infected, it's very important that we have prevention here, starting from VCT, voluntary counseling and testing, so that they know they are positive. And at this stage, there are two things that they have that needs to be done. First of all, to ensure that they have the knowledge and the services to prevent AIDS, so that they don't become sick. And secondly, that they have the courage to say, HIV stops with me. I will not transmit to anybody, either through sexual or through my sexual behavior, as well as injecting. And if somebody is already, so we have the prevention here, and even if somebody is already in AIDS, then they have the right to have antiretroviral treatment, treatment for opportunistic infections, and all the care so as to prevent death. And even if they are dead, we have to prevent that at that time that they have to die in dignity and not as we still have to respect their human rights. So prevention policy and programs have to be integrated with care and treatment along this continuum. Several essential policy issues. I don't think I will discuss them in detail, Paisar, because we also have to look at the time. First, ensure human rights and fight stigma and discrimination. I think a lot of speakers have already talked about that. And again, it's easier to put it on paper than to carry it out. Although over the years, I myself have seen that if we consistently insist that we are fighting for the human rights of all of them, whether they're sex workers or MSMs or injecting drug users or whatever, they are still members. They're still citizens, and by law they are protected. Their right to live, their right to life, their right to health, their right to education, and all that. So this has to be clear in all policy statements, but also in programs. And stigma and discrimination is not only against those that are already infected, but actually stigma and discrimination before they are infected. Because, for instance, in some countries, men who have sex with men are considered sinners, so that they do not have access to services. The same is for instance, drug users. They are criminals, etc. So we have to fight stigma and discrimination before they get infected, as well as after. Promote gender norms